All right, Dr. Furlan, thank you so much for joining us on the podcast today. It's a pleasure to have you.
Oh, thank you so much, Brian, for inviting me. It's a pleasure to talk to you today.
Obviously, you have done such an amazing job with education and communication, and really not only teaching, your patients, but thousands and millions of patients across the world. Everything that we do in pain medicine and everything that we think about for as far as trying to help these patients to, cross that bridge from where they are to where we're trying to get them. But I think one of the things that would be really helpful for our audience is really understanding how we can do that better as practitioners, right? Most of our audience is, medical students, residents, fellows, early career providers. How do we start utilizing, all of the things that you teach to be able to communicate better with our patients?
Yes, good question. And I wish I knew 30 years ago when I graduated, when I finished my residency, what I know today. My life would be so much easier because I think when I graduated from physiatry 30 years ago, unbelievable. And I think I thought that I could help and cure everyone with pain. And I chose physiatry because I wanted to treat pain. And I find physiatry one of the best specialties because we see the person as a whole. We focus on function and we treat, with a biopsychosocial approach. And we have, usually we have a team. So I think it's one of the best specialties to treat pain. But I think after 30 years, I have to be humble that I can't help everybody the way they expect me to help. So I think everybody comes to a pain doctor, like when they come to us and they want, the pain to go away. That's what they want. And in many circumstances, it's hard because we know after some nociplastic changes happen in the pain system, they are basically irreversible, unfortunately, and the pain can become a permanent feature or fixture of their body and their brain. But it doesn't mean that we should not help our patients. It doesn't mean that there's nothing we can't do, but the help looks a little bit different. I think we need to help them to function, to live happy lives, fulfilling lives, with least amount of medications. And it is possible. I think you and I, we have seen people that this is possible. So I think this is what I like the residents, medical students who are starting their career, is that you will be frustrated sometimes because you will not be able to help people who have pain. But it doesn't mean that sometimes just by listening to your patient, giving them attention, understanding what's going on in their life, and reassuring them everything is okay, you're not broken, you're not all dismantled, your body actually can do a lot of things. You are helping more than you can think. Just listening. Sometimes just listening, you're helping them a lot. I don't know if you agree with me, Brian, but our patients like to talk. They like to tell their stories, right?
Absolutely. Yeah, I think one of the things that's you learn by doing this over years and years is that a lot of what the patients need is to be heard and then to be educated, right? I mean, so much I feel of my job now, which is much different than I would have thought, 12, 15 years ago, is to listen to the patient, to hear them, to help walk them through what they've gone through already, and also to be able to try to teach them about the things that are missing from their understanding of what's going on for them and how we view it from the side of the clinician, right? I think that's such a hard journey for the patients to take, but the better that we are equipped at being able to help them along that journey, I think the quicker that we can actually help them to to be able to make it to that point where pain isn't running their life, but they're living with the pain.
Yeah. So what I developed in my life, I think I accumulated a number of quick responses. So it's almost like in my brain, I have little drawers. And those are drawers that I have responses that I kind of prepared over the years. And because, Brian, I think we physicians, we are not good salespeople. I think we need to learn better how to sell. I'm amazed at people who study marketing. Actually, the most of the books that I'm reading right now are about marketing, because I need to market the idea. We need to sell an idea. That's what we do, physicians. We are here to we make a diagnosis, and then we have a plan of treatment, and then you go and you explain that to the patient. But if you don't use the right words, if you don't use the right analogies, if you don't speak their language, their level, or ask what they are understanding, they're not going to buy your idea. It's like buying a car. Like if you're not a good salesperson, you're not going to sell cars. You need to sell, and we sell a treatment plan. But you can have a perfect diagnosis. You spend a lot of time examining the patient, and you come with this drug that is going to help them. But what if they don't believe that that's going to help and they don't take it?
Yeah.
You are a failure. We are a failure because we were not able to communicate. So I think if I can give an advice to anyone who is starting their career, and this would be an advice to me 30 years ago, is invest some time learning about communication. Learn with communicators. There are so many books, so many videos, so many resources, courses that you can attend. And marketing is amazing because they need to sell products. Learn how they do it, what language, and have those. That's what I'm trying now. I think that having the YouTube channel helped me to come up with messages, because I do need to record one video. So I prepare the script, I study, I prepare the script, and then I record. And my videos, I try not to repeat the same thing many times in the video. So it has to be pump, 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 pump. And that's what I do now with my patients in clinic. When I have an idea that I want to say, for example, like today I was in clinic and a patient came and I had to explain that, the patient has nociplastic pain. That's the diagnosis we made. How do you explain that the pain is nociplastic? It's a beautiful diagnosis. Okay, wow, this is, explains everything you have. But how do you sell that idea to the patient? If they don't understand, they're going to abandon you because they're going to get the wrong message. Maybe they will think, oh, this doctor doesn't believe that I am in pain. She's gaslighting me. She's, thinking that my pain is imaginary, psychological. That's not what I'm saying. But if I don't communicate well, that's what they're going to understand.
Yeah.
So I learned that patients like a lot of analogies. They love analogies. And I have a number of them. You probably heard me on my videos. I talk a lot about this, the analogy of the alarm system. I didn't invent this, and I have no idea who invented, but I borrowed. They love it because they can relate to, the alarm system of your body, the nociceptive, neuropathic, nociplastic. I'll just briefly explain this here. Nociceptive is the alarm system, like the pain is the alarm system of your body, similar to an alarm of a house. So you install an alarm in your house because you want the alarm to go off when there is something wrong with your house, like a fire, smoke, a burglar, break-in, a flood in the basement, etc. So you install sensors, and we have sensors in our body for everything, for all kinds of pain, burns, heat, cold, electrical shocks, and pressure, etc. So when you have nociceptive pain, that is the pain that it means that there is like a fire in the house, and you need to call the fire truck. And they come, they put up the fire, and the alarm stops. So an inflammation, a fracture, a toothache, a surgery, you cut, a skin, that's nociceptive pain. Now, neuropathic pain is when the wires of the house are in short circuit and you open the cupboard of the kitchen and the alarm goes off. So you need to fix the wires, right? And but there is something that you can fix there in the house. It's a hardware problem. There's something fixable there in the house. Now, nociplastic means there is no fire, there is no breaking, there is no short circuit, there's nothing wrong that you can fix, but the alarm is going off all the time. It's just because the alarm is deregulated. So you need to call, you don't call the fire truck, the ambulance, or the police. They're going to come, they say, there's nothing wrong with your house, but you need to call the alarm company. And that's nociplastic pain. It's a problem of neuroplasticity. Imagine living in a house where the alarm is going off all the time, all the time. It's super loud. That's nociplastic pain. These patients are living. And at that point, Brian, when I explain this to the patient and I look at them in the eyes and I tell them, listen, imagine, I can't imagine how it is for you to live with this chronic pain, because it's almost like living in a house where the alarm is going off all the time, constantly, very, very loud. Nobody can hear. People in your house think that you're crazy. You call the fire truck, they come and they say, there is no fire in your house. You must be going crazy. You're inventing this. You go from doctor to doctor to doctor. They do exams, tests. They can't fix you. And you are doing this for 10, 20, 30 years. You're trying to fix this problem. This is a problem of your alarm system. At this point, Brian, they start crying, because they say, this is exactly how I feel.
Yeah.
So now when they know that you know how they feel and you know what they have, anything you're going to tell them, they're going to believe and do it.
Yeah. Yeah. I love I love that analogy though, right? I mean, I too love analogies. I think it, like you said, it's a great way for patients to be able to really understand it, right? The hard part is taking these complex topics. Nociplastic pain is a complex topic that I think even, probably most physicians don't fully understand. But at the same time, being able to make it where it's relatable, right? And so I can totally see how, you explain that and the patients start listening, right? They're actually opening up because, like you said, for that first time in a long time, they're feeling as though somebody is actually understanding what they've been living with. And that understanding opens doors to being able to kind of move things forward, right?
Yeah. To try some things different that they didn't try before, because I get patients that they had this pain for 10, 15, 20, 30 years, and they tried everything.
Mm-hmm.
So now they're open to try some things different. And one of them, which is a very hard pill to swallow, is if they are on multiple painkillers, they need to stop, because those painkillers are doing nothing. Actually, if they are on opioids, we know opioids make nociplastic pain worse. And it's hard for someone who is in pain, chronic pain, to hear, wow, but I need to stop taking the only thing that seems to work.
Yeah.
The other thing is that they need to exercise. We know that exercises regulate this pain system, and they need to take care of their sleep, and they need to take care of what they eat. It's a lifestyle modification to fix the pain system. But again, they're not going to do these things like stop opioids, start exercising, take care of your sleep and your diet, if they don't understand why I am asking them to do this. So I think we need to spend time educating our patients, and we need to be good communicators.
Yeah. Well, and obviously the things you brought up, those are probably some of the hardest things in all of society to change, right? I mean, everybody, even physicians across the board, and I'd say people in general, those are some of the most challenging topics, right? How do you eat well? How do you exercise well? How do you make sure you get enough sleep? How do you take care of your mental health? How do you make sure you're fitting in your deep breathing and your meditation and all of these things that, for the vast majority of us, we don't necessarily hit all of these things on as consistent a basis as we would like to, or as we probably should. And we're asking our patients to do that while the alarm's going off. And oh, by the way, we're also going to try to convince you that we're going to stop all these medications because we think it's best for you, because the data says it is, right? But it is this process of how do you gain that trust, gain that acceptance, and walk them through it. And I think, like you said, I think those steps of first establishing it, like you just brought up, are a really great way to start the conversations. As you've been evolving your techniques, your way of communicating over the years, and I know you said that the YouTube channel has really helped you with the communication. Have you found that being able to direct people to the channel being able to direct people to, I mean, even just you as an authority figure, right? I mean, obviously, even before the YouTube channel, you were an authority figure with a lot of the research that you've been a part of and a lot of the papers that you've helped with. But being able to show that in this modern way for patients to see, yes,
Yeah.
this is somebody who is,
Yeah.
very knowledgeable, but at the same time is right here in front of me, empathizing with me and trying to help me to move forward with this.
Yeah, I've seen that the channel has brought some credibility to my message. So before I had the channel, like as you said, I had papers, I published guidelines, but the patients did not know.
Mm-hmm.
They did not know my CV, so they came to a consult at the hospital and they were just matched to see me and they had no idea. Maybe they did some Google before they saw me, but they're not going to read my papers and my guidelines and know, that I'm a scientist, I'm a professor of medicine at the University of Toronto. Who cares? They want me to solve their problem.
Sure.
But I think with the channel, what they see, and they tell me this now, is, okay, so there are two things that happen. One is I get people that they now ask to be referred to me because they know me from YouTube. So they come with some level of kind of knowing who I am, my credibility, my messages. They know already what I'm going to say because they saw me on YouTube. And then there are others who have no idea that I have a YouTube channel. Like one of the patients today, a gentleman there, and I said, "Did you know that I have a YouTube channel?" He said, "No, you do?" And I said, "Yes, I do." And so they're surprised. And I would say what they like most is not just the videos, but they love the comments that people write. And that is an attestation that it works because people write. I have thousands and thousands of comments. And people write, saying some people don't agree with what I'm saying. No, not everybody will agree. But then there are thousands of comments saying, "Wow, this works. And I did this and my pain is so much better. My quality of life is so much better. You changed my life. Saying thank you so much, Dr. Furlan," and blah, 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 blah. So I think like you, Brian, if they come to see you, I think they wish they could talk to other patients that were treated by you, but we don't promote this kind of conversation between our patients. I think, the old-fashioned physicians that had a community of practice, they are the community physicians, and all the patients are waiting in the waiting room, and they talk to each other. Now they could exchange ideas, but they don't do this anymore. Like, how do you put one patient that you treated that had a good outcome in touch with another patient that you were just seeing starting their journey? And I think that's what's happening with the YouTube channel, because they start doing like one video, they change their diet or they are doing exercise, and then someone puts a comment, and then the other person will ask them questions, and that's the first person will respond, and they start having a conversation, and they kind of coach each other. I just listening to the conversation because I have to approve every single comment.
That's smart.
That's how I set up my channel. So I need to read every conversation. And that's really, really interesting. I think our patients need to hear from other patients. They need to hear those testimonials. That helps. Actually, that helps much more than sometimes what we say.
100%.
They will come and they will say, "Dr. Furlan, I saw your video about myofascial pain and someone there got better. How do I?" And they tell me, "I just came here because I want to see if I'm doing the exercise that you show in your video correctly." And then they demonstrate to me. I said, "Yes, you are doing everything correctly." But they believe because they saw the comments of other people who got better.
Yeah. It's an amazing thing. I think obviously, not everyone's going to be able to create a YouTube channel, especially with the breadth that yours
It's a
has.
lot of work.
Yeah. But, but like you said, I think that there's so much in that patients seeing other patients succeeding. I think, in our office, we play some of our educational videos out in front, and, we'll be talking about, somebody's talking about radio frequency ablation. Right. And, invariably, whenever there's a procedure day, somebody's gonna be like, "I had that and it was great. I did really well with it." And then, you walk down the hall and you see this rousing conversation happening where, now these patients who, may or may not have been open to the idea of a procedure,
Yeah.
or may or not have thought about things, are seeing their minds opened because of these interactions with other people, right? And I think within academic settings, especially, I know when I was training at UC Davis, like we tried really hard to create these groups to be able to
Mhm.
have avenues for the patients to do that. And like you said, it's not the easiest thing to create, but whenever possible, trying to help them
Yeah.
to see that there are people that were in your situation that have been able to do this, that, or the other, and have made progress, have moved things forward. I think it's such a powerful thing for all of our patients.
Yeah, I don't know if you know, we just published a randomized trial in JAMA in May, and that was about tapering opioids. And so the intervention was basically a very intense education to people who were taking opioids for chronic pain. And one of the things that it really worked, the control group didn't receive the same
Intervention.
extensive, yeah, all this intervention. But one of the things that the people who were able to taper opioids in the intervention group, what they said was the testimonials, because the people who were training them, one was a nurse and the other one was a patient who had lived that experience of
Mm-hmm.
having chronic pain and tapered opioids. They were the trainers now. And they said seeing someone that had walked this walk and did this encourage them to try tapering the opioids.
Yeah.
So we do need to enable this conversation.
Yeah.
Someone who had a RFA, or someone who tapered the opioids, or someone who was reluctant to start exercising and did. Again, the lifestyle modifications, I don't think everybody needs to do everything, but some things will work better for some people, and they need those coaches. I really think they need a personal coach,
Mhm.
but that has to be a person that walked their walk.
Yeah. No, I think those are amazing insights. And I think, as we're thinking about ways to be able to, optimize this care for the patients, right? Obviously, it would be great. And I think there are a lot of communities now that are starting, and digital resources that are starting to be able to help connect people better, right? And so hopefully that's going to continue.
Yeah.
But as we're kind of thinking about our average listener here now, with maybe they're in residency or fellowship, and they're starting to think, okay, they listen to all of your videos, all of our videos. They understand the science aspect, right? They know the medications, they know the procedures, they know these things, but we're really trying to figure out, okay, how do I take all of those things and start to integrate it in a way to be able
Yeah.
to truly impact patients? I think that's actually a great segue to kind of bring in your book, which
Yeah.
is absolutely fantastic. I know, and this was actually written for patients, and
Yeah.
more directed to patients, but I think there's so much for people who treat these patients to learn from it, right? And trying to figure out how to help the patients kind of walk through. You use the analogy of climbing up the hill. I usually use the one of crossing the bridge for the patients, but I mean, obviously very similar visions for how to kind of help our patients on our journeys.
Yeah.
So
Yeah.
like, as you're thinking about, people earlier in their career, and really getting a framework and an understanding of how to take all of the science and all of the literature they've read and all of the hours in clinic that they've learned from their attendings, how do you now wrap that up in a way utilizing a lot of these techniques to be able to really impact patients
Yeah.
moving forward?
Yeah. Like the field of pain science has advanced so much, Brian. Like again, when I finished residency 30 years ago, we knew about the endorphins. We knew that the brain has a big power, but we did not have functional MRI when I graduated, and we did not know exactly what was the function. What does the brain do with all of this information that it receives and creates? It's now amazing what it can do, all the amount of medications that existed and we can use, like buprenorphine. It's a lifesaver for my clinic, especially for those people who are trying to stop opioids. The interventional approaches, even the physiotherapy field has advanced. So there are so many things. The psychology field, now we have pain reprocessing therapy, has an amazing intervention. Yeah, how do you put all this together? And that was like in 2019, when that was the year that I turned 50. So now you know how old I am. And so when I turned 50, I had this idea in my head. I think when I was in medical school, me and my colleagues, we ask ourselves, when do we know a lot about medicine? When do you know? Because when you just finish your career, you know all the theory, but you don't have a lot of experience. And at the end of your career, you have a lot of experience, but you're not learning anything else new. So I had this idea that we kind of established that when you are 50 years of age, it's the highest of your career. It's totally arbitrary. I have no idea if this is true or not. But anyways, when I turned 50, I said, okay, if from now I'm going to decline, I need to put everything that I know into a form of to leave this as a legacy, because I thought that I knew a lot about pain. And then I asked my son, I said, should I write a book? And she said, no, mom, nobody's going to read your book. Nobody likes to read a book. Open a YouTube channel. So, okay, I opened a YouTube channel. I started recording with my cell phone. This was my camera for a long time. Here, this is my room where I record all of my videos. I started recording myself here, everything like one video at a time. And I started this because I wanted to educate my patients. Like, I don't have time in the clinic, at the end of the clinic, to teach them. Like, if I make a diagnosis of fibromyalgia and osteoplastic pain, they immediately ask me, what is this? And if I don't explain, guess what? They're going to go home and Google, and who knows what they're going to find on Google.
Yep.
Something good, but could be something bad. So I said, I need to educate them, because I don't want them to find something that is going to be destroying their, there are so many groups in Facebook that are not healthy, and and so my videos were more like an extension of my clinic, everything that I wanted to teach them at the end of the clinic. But after having almost 100 videos, and I got that plate there, when I crossed the 100,000 subscribers, I contacted as an editor. It was a cold call. I called a book editor here in Toronto, because I chose them. I said, I'd like to publish a book, because then the book was basically putting all of that information together in a stepwise form. So I think not everybody needs to write a book, and not everybody needs to read my book. But I think for anyone who is starting a career, it's helpful if you have an approach, like something where you start, and then what is the next step? Where do you go next? Especially because chronic pain, there are so many things these people can buy. They can buy mattresses and massage, and they can try acupuncture. So they can spend money, thousands and thousands of dollars, and not get better, when the solution sometimes doesn't cost any money. It's just lifestyle, thinking differently, and behaving differently. So that's basically the 8 steps of my book. The first few steps is thinking differently. Retraining your pain system means, okay, let's see what pain really is, how your emotions affect pain, and then start taking care of your sleep, what you eat, your exercises, how you relate with other people, because our social environment affect a lot how we feel, we perceive pain, and then having your goals. And then we talk about exercises, medication, interventions. Those things can be added, but I put them at the end, down the road. I didn't talk about medications, injections, interventions in the beginning, because I don't want them to think this is the solution for all kinds of pain.
Yeah, 100%.
Yeah.
Yeah, no, I love the way that you built it, right? And talking about, the first step is just that education, that understanding. How do we make sure that the patients understand, the difference between nociplastic pain and nociceptive pain, right? The difference of understanding that, what kinesiophobia is, or something along those lines, so that the patients get that it's, it is not just that, I have knee arthritis, that's why my entire leg doesn't want to work, right? Well, that doesn't really make any sense. And so I think starting with that process, and then, as you said, then you just kind of step up from there. Okay, well, now we have the education, we control our emotions, or because emotions play a huge role in our perception of pain. and then and then working on all those lifestyle modifications. I think for for a young practitioner who's obviously learning all of this, they hopefully understand how important all of this is in being able to help our patients. But the way to have the conversations, I think, is the part that really is the art, right? I mean, everybody always talks about,
Yep.
there's the science of medicine, there's the art of medicine. So much of the art is being able to teach patients these things in a way that they actually hear, in a way that they actually learn.
Yeah.
And that's actually one of the things that I think your book did a phenomenal job of doing. And I think one of the things that would actually be really useful for earlier career providers to look at, because the way that you're able to break down these complicated topics, and present them in a way that is very approachable and is very matter of fact in the way that it's presenting them, so that it's not, it doesn't strike the emotional side of the patient when they're like,
Yeah.
you're saying I don't know what my pain is. No, that's not at all what it is, right? Like, we're not trying to provoke these emotions. I think you
Yeah.
did a fantastic job of that. And so I think those are the skills that, when we think about being able to have a career for 30 years, a successful career for 30 years, like, those are the skills that are really the differentiator, not necessarily, being able to quote all the literature, which you should. Residents, fellows, you should be able to quote the literature, but that's not what's going to actually make you as successful in your career as I think people think it will be.
Especially with pain. I think if people come, I don't know if that would be different, but if they come with an infection and you're going to treat antibiotic, they only want the prescription for the antibiotic. They want the right antibiotic, the right dose for the right period and buy. Like, you don't need to, you know, educate them about the bacteria and all the types of, they only want the right antibiotic. But in pain, because pain is suffering, a
Mhm.
lot of, now we know this from science. There's a lot of science backing up what I'm just saying. Okay. And your residents, I want them to pay attention to this. When a person say that they are in pain, it may not even have nociception anymore. Pay attention to this. They may not have nociception. The nociception may have finished, but they are still saying they are in pain. They're really in pain. But what you are really measuring or getting into, if you could do a functional MRI of their brain, you would see the areas of the emotion of pain, like the limbic system, the amygdala, the prefrontal cortex, the HPA axis is superactivated. So basically what they're telling you is, I'm suffering a lot. So you have a person in front of you who is suffering a lot, and pain is so stressful. You do need to, first of all, listen, be compassionate, and give your best explanation. And tell them sometimes when you don't know. Sometimes I tell my patients, I don't know what you have, but we'll find out what it is. We will work with you. We'll try this. We'll see how you respond. If you respond to this, it means that it was what we were thinking here. Like if they respond to anti-inflammatory, it's more nociceptive, because the only type of pain that responds to anti-inflammatory is nociceptive. But you're taking this ibuprofen for 10 years and you still have pain, so it's not nociceptive. So, but we can tell them what we are thinking. Or the other thing that I like to give to your residents, when you're examining the patient, doing your physical exam, can you please tell them what you are doing? Don't just do the physical exam in silence and then, oh, here's your diagnosis and here is your prescription. The patients love to learn why you are doing what you are doing, why you are prickling them with something sharp. What are you looking for? So I love to explain when I'm doing like a pinprick sensory exam. I'm telling them, now I'm testing the sensors. Remember the sensors of the alarm of the house that we install sensors in the walls? I'm testing if the sensors are working or if they are sensitized, they are too much or too little. So they love it because now they understand why we are
Mhm.
provoking a lot of pain on
Yeah.
them. But now they understand our rationale. So at the end, when you come to a conclusion, you have more neuropathic pain. Because remember, when I did this test with the paper tissue, which is not supposed to hurt, and you had pain, that's called allodynia. That means that, there is some short circuit somewhere. And then they understand. Because if you say it's neuropathic pain, here's an antidepressant, bye bye.
Yep.
They say, oh my God, that doctor is crazy because I'm not depressed. I have pain. I'm not going to take this antidepressant, because they go on Google and they find, the medication just prescribed is for depression. They say, no, the doctor is wrong.
Yeah.
But if you explain, then chances are they're going to take the medicine.
Yeah. No, it's such an amazing thing. I mean, yeah, you couldn't be more right about how, these conversations need to have. And obviously, who better to teach us about having great conversations than somebody who's been able to have them with millions of people across the country and world. But honestly, Dr. Furlan, I really do appreciate your time. I think that was a great way for us to kind of leave our audience in terms of a great tidbit of knowledge to go.
My pleasure.
But thank you again for joining us. And
I'd like to congratulate you. You are doing an amazing job spreading the knowledge of pain. Congratulations. I hope you all the best. And
thank you.
If you need me in the future, I'll be happy to come again.
Awesome. I look forward to it. All right. We'll chat soon. Okay.
Okay.
Bye now.